Next is malignant melanoma. It's V24. 39-year-old lady presents with a pigmented lesion on her leg. It has recently increased in size, got darker, and become nodular. What important information would you ask in this history? So she had a lesion, now it's changing. So we should ask about the history of the lesion, presence of pre-existing lesion, change in size, shape, color, bleeding, itching, ulceration. Then ask her any other risk factors of melanoma like sun exposure, cumulative childhood burn, sunbeds, easy burning, post-medical condition causing immunosuppression, and family history of skin cancer. What would you look for the examination? A, B, C, D, E. A for asymmetry, B for border irregularity, C for color, D for diameter more than 6, and E for evolving extra features, bleeding, itching, and elevation. Ideally, dermatoscopy should be done. Following initial investigation, you are suspicious that this lesion is malignant melanoma. What are the risk factors for the melanoma? So melanoma risk factors: Fitzpatrick skin type 1, sun exposure and sunburn in childhood, presence of other skin lesions, previous melanoma, atypical Neff syndrome or congenital pigmented hairy nevus, and organ transplantation, albinism, xeroderma pigmentation, and family history of melanoma. How would you manage this patient? So first of all, we will mark the area and photograph the lesion, confirm the diagnosis by performing an wide excisional biopsy with 2 millimeter peripheral margin with a cuff of fat. Once the diagnosis is confirmed, the patient should be managed by the specialist skin multidisciplinary team. A wide local excision of the scar is performed. The peripheral margin of which is determined the breast-lobe thickness of the tumor. This aims to improve the local regional control by excising any possible micromets around the site of the primary lesion. So what are the main histological subtypes of melanoma? So superficial spreading, nodular, lentigo maligna, and acral lentigious. So most common is superficial spreading, then is nodular, then is lentigo maligna. So what is breast lobe thickness and why it is important? So breast lobe thickness is the depth of the tumor invasion measured from the stratum granulosum of the epidermis to the deepest part of the tumor. The peripheral margins taken during wide local excision of the scar are based on the lesion of the breast lobe thickness. So the histologist from this external biopsy will tell us what is the breast lobe thickness. So if it's less than 1 millimeter, then we need 1 centimeter peripheral margin. So we need to go back and excise that scar. If its breast lobe thickness is 1 to 2, then we need 1 to 2 centimeter margin, and if it's 2 to 4 or more than 4, then we need 2 to 3 centimeter. So who would you offer sentinel node biopsy to, and what are the risks and benefits of this? Sentinel biopsy is offered for stage 1B and stage 2C patient with a breast lobe thickness greater than 1 millimeter and aims to identify the first nodes in the regional lymph node basin which drain the area. So it's a prognostic indicator. It's performed at the time of wide local excision. The benefits are potential earlier identification of the tumor that has been spread to the lymph nodes, prognostic information, and access to adjuvant treatments. The main risks include the infection, seroma, bleeding, lymphedema, false negative rate around 3%, failure to look at the sentinel node. What is the management of a patient who has a positive sentinel node? So again, it should be discussed in the melanoma MDT. The patient should have full staging investigations, CT of the head, CT of the neck, CT thorax, abdomen, and pelvis to exclude any other disease. If there is no other obvious disease, the patient may be offered complete lymphadenectomy. More recently, there has been a shift towards the radiological surveillance versus surgery, and there is no survival benefit. Then they keep the lymph node on surveillance because surgery increases the morbidity. How is melanoma classified? It's TNM classification. I don't think so. We need to do it. How is melanoma stage? Again, don't need to do it. So what are the treatment options for with stage 4 disease? Is a biological agent depending on the BRAF gene. I think that's enough for us. Thank you.